breathe, sigh, breath of relief there. Where they were investigating the accuracy or the use of CT etc. You might want to get a CTPA. Complex cases get CTPA, especially those with severely abnormal chest x-rays. VQ scan has no role in the assessment of hemodynamically unstable patients who present acutely. Who do you get a SPECT VQ in? Perhaps in those in whom the previous criteria I just spoke of don't exist, who have normal or near normal chest x-rays with minor anomalies, patients with renal dysfunction, patients with contrast allergy. You might want to get a SPECT VQ. You might get a SPECT VQ in patients with pregnancy and normal chest x-rays. And all cases of follow-up are usually, after a diagnosis of PE, this is usually assessed by SPECT VQ. And patients with long life expectancy, greater than 10 years, should be assessed by SPECT VQ in order to mitigate radiation risks. And that should be it. Thank you very much.
Thank you very much, JC. I think in the limits of time, I think we'll take some questions after the next talk. So our next speaker is Dr. Mark Landis. Mark actually did his medical school at the University of Toronto and did his radiology residency here at Western, as many of you know. Mark then returned to Toronto to do subspecialty radiology training in thoracic CT and now come back to London to sort of be the thoracic expert here on CT. He has a particular interest in the cancer program for lung disease. And Mark, throughout his time here, has been really a strong supporter of the emergency department and has a particular interest in knowing the clinical features of what we're looking at. And so he's always happy to talk to us about cases. So Mark is going to talk to us specifically about CTPA, the diagnosis of pulmonary embolism.
Does this work? Hello? Oh, okay.
Here we go. Thanks, Mark.
All right. Good morning. Nice to see familiar faces and those I've not met before. I am the voice on the other end of the phone at Victoria Hospital. I feel like the guy Tony Robbins, the guy with the big teeth walks around. So initially I was asked to talk about CT pulmonary angiography as it relates to workup of PE, but largely this, in target audience, this I think gives opportunity for a larger discussion around imaging utilization in the workup of patients in whom that you suspect embolus may be a possibility. Now, I put the title as appropriate because on all fronts, it's PE, right? What are we going to do? It's one of these diagnoses that are annoying as stink, and also from a management perspective as well. So my objectives here are to review current imaging algorithms, and J.C. Warrington's already kind of spoken to that effect earlier. Review our existing utilization trends, not necessarily at this center here, but more broadly within the ED and radiology community. What triaging strategies do we have at our disposal for this, and what guidelines exist to help guide our choice of what modality and test to go with next? Review some challenging clinical scenarios, not only from a clinical perspective, but also from my perspective in terms of how we come up with a diagnosis, and pray God do not fall asleep. All right, so why is PE annoying? Well, clinical presentation is all over the map, right? The textbook presentations that we learn about in medical school and earlier on do not really follow. There are so much heterogeneity. But the diagnosis is obviously important, and why is that? Well, in the ED setting, a large volume pulmonary embolus has significant consequences vis-a-vis cardiorespiratory failure and ultimately death. But if it goes undertreated, or more broadly underdiagnosed and undertreated, The chronic sequelae are important, and we see these not only amongst our respirology colleagues here, chronic thromboembolic disease and subsequent pulmonary arterial hypertension, which unto itself has a significant morbidity and mortality due to evolving right heart dysfunction and death. Now, fortunately, the old historical ideas of the massive PE with those, I forget what the ECG criteria or STQ, it's been a while. They don't have a significant clot burden, fortunately. Most of the time, these patients are hemodynamically stable, and as such, given their heterogeneous clinical presentation, there's a lot of symptom overlap with multiple pathologies that you're kind of contending with in an ED setting, and it's like, hence the WTF statement of how are you going to work these up. Now, how do we currently evaluate and establish a diagnosis? Well, there's the clinical grounds that we've spoken about, but that, as we've already seen, is somewhat variable. And then there's obviously some element of evaluating either the pulmonary vascular system or the venous system more broadly, and these have already been kind of elaborated and discussed earlier. So just to contextualize it, the old direct pulmonary angiography is a bygone thing. The only role that currently serves, so the DSA where there's a venous puncture and we do injected angiograms of the pulmonary arteries, is usually in the setting of intervention. So targeted catheter-based thrombolysis, for example, really has no real role in the emergent diagnosis. As JC has already alluded to, scintigraphy and CT are the workhorses for that. Now, looking from my end of the world, the whole idea of CT and its application really came about, this is fairly recent-ish technical innovation, came about in the early 90s, and that was using older technologies. So single detector eventually evolved into multi-detector, and we got better. You know, in comparison to direct catheter-based angiography, our ability to pick up segmental, arguably clinically significant emboli, improved significantly. Subsegmental vessels in these lower technology CT examinations was less. However, as our technology got better, as is the norm, think of iPhone 4 to 6, things arguably should be getting better. Our resolution improved. Our ability to pick up subsegmental emboli improved significantly. There was improvements in inter-reader availability, and as an end user, you were more comfortable in requesting these sorts of examinations because the diagnostic improvement was so much better. Fast forward to 64 slice CT, which is now essentially the norm in most community and certainly here at LHSC. Our sensitivity and specificity is now greater than 90%. And the important thing I need to qualify is that CT pulmonary angiography and a multi-detector 64 slice is not a panacea. It is a bit more technically involved from our technical staff's perspective in terms of making sure it's a good quality examination, and our techs do a very good job in doing that sort of stuff. And what it assumes is that you have proper opacification of the pulmonary arterial system. Right? You want to make sure that you're making sure you don't have a lot of respiratory motion, which really muddies the water. And patient physiology is also somewhat permissive. Now, it's kind of, a bit of a challenge in those patients in whom they have, for example, poor cardiovascular reserve or function, and those types of patients who worry about that, their own, as they come to the scanner, can kind of the quality of the examination. And we don't see it, and we do see a relatively frequent, technically inadequate examination. 7.5% is a reasonable ballpark in those, and it's for those reasons in particular. Now, there was a question about, if you get a CT scan here at Victoria Hospital, is it the same that you'll get up at UH? Is it the same as you get at that same dose? The answer is yes. There is relative uniformity across the city vis-a-vis the protocols that we're doing for them, so you should feel comfortable that from a technical perspective or hardware, you're going to get the same sort of thing. So the only real issue that will come into play from your ordering perspective will be, is your patient able to tolerate it for the reasons that I've already mentioned. Now, while we've got very good diagnosing PE, we've also seen when something works well, use it regularly. And there's an increase with the advent and development of CT for PE, and most studies have shown this, to the point where you're seeing now a threefold increase in overall diagnosis. But remember, we're seeing now things that are segmental in the vast majority of cases. And you're arguably seeing less severe burden of illness. And the question is, are there mortality benefits that are conferred by improved sensitivity? And backtrack here. What is Landis talking about when he's talking about a pulmonary embolism? Well, this is an example of one that's here. Arrow sign, unfortunately, doesn't come on every examination. But to contextualize here, we use what's called a bolus tracking, or a technique where our technologist will place on the main pulmonary artery a region of interest, and as we see, as a contrast bolus comes through with test slices, once we see optimal enhancement, which I'm not going to bore you on those details, we'll set the scanner to go, and you should get a good pulmonary angiographic picture. And these are the filling defects that we're looking at, and that's what will get reported to you guys. So this is a clot in the distal interlobar segment artery to the right lower lobe. So getting back now, are there mortality benefits created? Well, a lot of subsequent analysis has shown that while there is an overall higher incidence in diagnosis, mortality rates haven't changed. So what are we referring to? And these are all American studies, and these are multi-center assessments of large data sets. So specifically, disease-specific mortality rates, case fatality rates have stayed stable. Now, does a similar increased utilization apply to postoperative cancer patients in whom we know they are at increased risk for DVT and subsequent VTE? Yes, there has been an increased overall utilization for the same reasons that I've mentioned to you, again showing that there is a less severe burden of disease, but also, interestingly, showing that for those indications or those indices that I talked about earlier, case fatality rate, et cetera, there's no real change in overall mortality. Now, you will get a report from me or from one of my colleagues talking about there are some little subsegmental emboli. Right, and we're wondering, well, what does that mean? How do we stick handle these? Because as this slide shows out junk, it filters this stuff out. So is this just a natural product of what we're seeing for normal physiology? We all will shower off little small emboli. Does it mean that we all need to go on anticoagulation? Arguably not. And there's data to support that. However, there is variability in clinical practice patterns, and to the point where the Cochrane collaboration tried to come up with some assessment and consensus in terms of how do you manage these patients. And to be honest, there really was no consensus arrived at. We've seen that there are stable rates of diagnosis of large and fatal PEs, thankfully. Increased diagnosis in subsegmental stuff, but what do you do with a subsegmental emboli? That's variable, and clinical judgment is needed. Now, from my understanding here at LHSC, the current approach, and this is born from that Anderson paper that J.C. Warrington showed the graphic of from the New England Journal, was that in the setting of a patient who has an isolated subsegmental embolus, a Doppler ultrasound should be done. And in the setting, if that is normal or no DVT, you don't necessarily need to initiate anticoagulation, and your follow-up examination is done. If it is positive, so i.e. we do have a true DVT, not superficial saphenous, for example, or superficial calf clot, you start therapy, and then you leave it to those guys to deal with as you would. So now let's just shift now from the diagnosis side of thing in terms of how are we approaching and working up these patients. So granted, it's been a little bit, but there's a reasonable case scenario I would imagine in a patient who comes through your ED where a lot of the hemodynamic parameters would, certainly embolus, amongst other things, may come into your clinical differential diagnosis. So let's say you're worried about PE, and I don't need to say this to this audience, you guys know obviously. The first one is a patient hemodynamically stable or unstable? If they're unstable, forget it, just let's do a definitive examination, see what's happening. However, our diagnostic dilemmas come in the patients I've already mentioned to. These are, on balance, hemodynamically stable patients. So it involves, as already alluded to, some element of a risk assessment and subsequent imaging. So there are different ways in terms of how you derive of this. There's the clinical gestalt, and these physicians walk in, smell the air, and this is an embolus, versus, and I've always had significant respect for that sort of stuff, versus utilizing a more structured approach. And there are clinical decision rules that exist for that. Now, the Wells criteria, fairly well established. I think there's some guy in the crowd named Dreyer. We've a guy named Kovacs who are involved in the actual development of those guidelines. It's a well-established and validated clinical prediction rule to help you guide in terms of whether or not you think a patient is at risk for PE. This one's an interesting one. PERC, derived out of the United States. And when I read about this one, this was describing whether or not you choose to order a D-dimer, okay, which is, I suppose, there's clinical prediction rules to govern imaging tests, well, in terms of ordering a blood test. The question and potential issue that I see here is if you look at one of the criterion, age above 50, if that is positive, this prediction rule argues that you cannot rule out pulmonary embolism in this patient, at which point then, you'll be potentially investigating a significant number of our patients. But from my understanding, this is not one that's uniformly used around here, but is one decision-making tool. And then the Europeans as well have also come up with a similar strategy, which is kind of based on the Wells criteria, the Geneva score, which again assigns points much in the same way and helps, at least put forth a potential post-test or pre-test probability for patients who may or may not have PE. Now, the D-dimer can be a hotly discussed point, either 2 in the morning versus 2 in the afternoon, in terms of its utility in working up these patients. And just to briefly remind ourselves what it is, it's basically a fibrin degradation product, and we should not be present in normal walking around patients. However, it's positive in a myriad of different conditions, and the group here is aware of what those are. And in terms of how we actually assess for the presence or absence of elevated D-dimer levels, there are variations in assays, and from my understanding here, we use a high sensitivity D-dimer assay, which should be fine. Now, current clinical practice recommendations are in the setting of a patient who has a low pretest probability and a negative dimer, you can safely exclude embolism and obviate imaging. It becomes more of a problem when you're getting into those moderate to higher risk patients, obviously. And as I've already mentioned, that if we think about the diagnostic performance of this approach, it calls into mind disease prevalence, method of how we're actually determining our pretest probability, as I've already kind of mentioned, and the sensitivity of the assay. And it's important to note that all D-dimer assays, as I've already alluded to, are not equal. And if you look at some of the sensitivities, 85% sensitivity in some studies, up to 97%, so I think wherever you practice, if it's here, if it's out in the community, it's important to know what type of assay you're using such that you don't run into potential problems. Now, guidelines, and I'll get into our Canadian guidelines because they do provide some at least more local help in terms of strategy, always calls for a thorough clinical evaluation. This is common practice to what you guys do. And judicious use of laboratory tests, i.e. the dimer. And it's been shown that excessive prescription of D-dimer testing and deviation from guidelines reduces cost effectiveness and creates increases in utilization of further tests when it may not necessarily be needed. Now, how do you choose to image and what imaging tests to use? And frankly, there's no real easy answer for it, as we've seen that there is relative comparative power in terms of diagnostic ability for CT, for example, and SPECT-VQ, as JC had alluded to. And it depends upon the referring clinician's risk tolerance. And the threshold has dropped significantly to image, depending upon whichever test you choose. But the mortality and morbidity hasn't changed, and there are a myriad of different reasons for that potential change in practice pattern. Now, as I've mentioned, CT will have a tendency to show less severe spectrum of disease than ventilation perfusion, and the treatment risk-benefit ratio will vary depending upon spectrum, and arguably there could be less benefit for a less severe burden of disease. Now, this was an interesting one in that, in terms of utilization, there was a study that was done which looked at, this is an American study which looked across different centers and put forth the conjecture that up to a third of patients who are presenting to an emergency department potentially undergo avoidable imaging for PE. And one of the reasons offered was the suboptimal utilization of pre-imaging tests. So for example, they cited in a patient in whom you identify wells, and again, this is the hemodynamically stable patient, not the unstable one, in whom you identify a Wells score of less than 2, or even in the 4 to 6 range, where no D-dimer is performed and imaging is done in the face of a negative D-dimer for those who have a Wells of less than 2. Okay. Similarly, there was suggestion that even in the 4 to 6 score range on Wells, when D-dimer testing is not performed, there can be potentially avoidable imaging tests performed as a result of those. And some of the reasons that were proffered, well, perception that CT pulmonary angiography is a better test. And it depends upon what you're asking to test for. As we've shown that if you're looking for embolus, yes or no, CT is good. Ventilation perfusion with SPECT is equally as powerful. If you're looking for an alternate diagnosis, not necessarily pulmonary angiography or PE, CT is good for that. And then it boils down to the question, and this comes down to the dialogue between us and SNU, what exactly are you looking for? Is it truly embolus? Are you worried about something else? Because if you are worried about something else, we'll be happy to examine the patient with CT, but the type of study that we do will be altered. And this is a timing thing, as I've kind of already alluded to. Okay? Now, this study also, it was interesting that it challenged some assumptions that we already have, in that cancer is a risk factor for DVT, and it is. And if you look at the Wells criteria, they go patients who are under active treatment, palliative treatment, or have been diagnosed within the last 6 months. Inactive cancer, arguably beyond those time periods, there's no real indication for that in a patient in whom you have a relatively low clinical probability or worry about when that is the only criterion that's being identified. And similarly, old age as well. Old age itself, is not necessarily an indication in a low-risk patient. So, what do we do from this? If you have a high clinical probability, don't bother with the D-dimer. Let's just move on to the next test that you think should be done. And if you have a low to moderate worry, a D-dimer can be helpful. Now, a D-dimer, as I'll show you, should not be ordered in isolation. You need to have your chest radiograph to help go along with that, because as I've said, there are different reasons. Now, interestingly, in the low to moderate risk patient, if you have a marginally abnormal, I'm not talking about D-dimers in the thousands range. Our cutoff, I believe, here is around 250, and if it's supranormal, how much of that is a true positive D-dimer rating? You could consider imaging, since the post-test probability is indeterminate, but we defer to your judgment in that one. So how are we going to do this? How are we going to image them? Where do I fit into this conversation? So if you look at the Canadian Association of Radiologists, they come up with a series of recommended imaging guideline strategies for that. And again, this assumes hemodynamically stable patient. If you have either a low, moderate, or high probability patient, the recommendation is you start with an X-ray if you're going to do anything, okay? And if you haven't, once that's done, if you have presence or absence of pleural or parenchymal disease, then you reassess. In a normal radiograph or marginally abnormal, as Jason said, so what I'm talking about by marginally abnormal, small diffusion, for example, linear plate-like atelectasis, for example, again, those by themselves in isolation don't exclude embolism, but in the context of your larger assessment of the patient should help to guide, okay? If you have pleural or parenchymal disease, that's when, frankly, you need to do some further test. And whether or not it comes to us or comes to the nuclear medicine colleagues, that can be done. Now, you've got a patient in whom you suspect embolism, you're going down your algorithm, and you think, well, we'll send them for so they'll have a low to moderate probability, normal radiograph. You send them for a set of leg Dopplers. Doppler is negative. does not necessarily, you can't exclude it. And particularly in a high probability patient, even in the setting of a negative Doppler, you still are compelled to go forward and do a further imaging examination. Okay? Now, I've already kind of alluded to this. CT angiography is a powerful examination. We've already done this, reviewed this data. And so you send the patient to me or to one of my colleagues. We diagnose an embolism. Great. Now, but we can do better as imagers to provide some prognostic significance. So times when I've gotten on the telephone with you guys has been where there's multiple emboli or other CT features that are worrisome and carry with it a future predictable mortality, i.e., and as we know, the biggest one is cardiovascular collapse. And there are certain CT criteria that exist that are good predictors of that. So one is overall clot burden. So the presence or absence of embolus is kind of binary. Clot burden in terms of number of segmental arteries that are involved is important to report. And I've tried to instill this in our trainees to catalog exactly the number of segments that are involved. Also looking at secondary findings. So what are other CT features that may suggest elevations in right heart pressure, pulmonary arterial hypertension, for example, in an acute setting? And these are some examples here. So top left picture shows a clot distal right proximal interlobar. Middle picture here is centered on the main pulmonary artery, and I hope it's this thing here. Okay? Suffice it to say, that's big. Okay? Bottom image here, centered on the right ventricle. This right RV is dilated. The interventricular septum, if you think about systolic function, it should be, the interventricular septum should bow during systole into the RV. Here it's flattened. That implies that there is increased blood volume within that, and that's a reliable finding, even on a non-gated examination. So these sorts of things either should be reported or, as an end user, ask your radiologist, are there any other features that are worrisome for PA hypertension? Because, as we know, mortality correlates, one, with clot burden and the degree of cardiopulmonary compromise. And there are good findings that can be made on CT that point to patients who are at increased risk for that. And therefore, it may trigger you to either consider ED thrombolysis, catheter-based interventions as well. So it's important for you guys to know that, and that's something we can provide. Now, the patient in whom you suspect PE and they are pregnant. Since the movement over to Vic of the obstetrical service from Joe's, this has become a far more frequently seen issue. And the estimates, if you like those statistics, are 11 in 100,000 patients. And it's highest in the postpartum patient. And you'll see those patients who come through your ED who've given birth and they are at increased risk. Now, JC showed that ATS guidelines thing in the assessment of the PE, the pregnant patient, in whom you worry about PE, and they say don't bother with the D-dimer. So I wouldn't even go there. But this algorithm that was shown, this is the same chart that he showed, is a reasonable algorithm, and the reference is here, so that's readily available to you. Now, so you want to work them up, and your patient will ask you, what's my risk? So radiologists and imagers, we tend to get mired in these esoteric measures and units for radiation, but what's an easier thing that can be understood is chest X-ray equivalence, okay? And JC is showing this. So I draw your attention to the last column on the right, and this would be the relative chest X-ray equivalent to a fetus, F, and mother, M. So those are the data there, and those are numbers and numbers of chest X-ray equivalents that you can quote to your patients should they ask. Now, again, why do we care? Well, risk of cancer, that's the principal one. The postpartum patient, these arguably are young patients in whom they have a significantly good life expectancy. And the overexposure of these patients to ionizing radiation does carry with it a bit of risk. And there's, again, there are studies which suggest that multiple repeat examinations have an additive increased risk. And as JCL already mentioned to you, in women, exposure to the breast tissue and lung tissue is the principal one, and where you'll see radiation-induced cancers have place. Now, in fetuses or feti, I don't know, the data is sparse. Okay, so, however, the absence of data doesn't necessarily mean that there's not a relative risk, because remember, these chest X-ray equivalents are based on phantom studies where we've done experimental examinations which show that there is some exposure to a fetus with ionized radiation when we do CT pulmonary angiography. Now, is there stuff that I can do as an imager to help quell that dose or cut that dose? Yes. Techniques exist, and we do those here. So there are dose reduction techniques which can be done, and patients can also receive a little bit of barium. And you're thinking, well, why are we giving barium to a patient? You're looking at the pulmonary vascular system. And it's important just to remember that the radiation exposure to a fetus is not from the external ionizing radiation. It is due to internal scatter. So these X-rays will be coming in from all sides at mom, but they'll be bouncing off all throughout her abdomen. So barium, high molecular weight agent, is very good at attenuating those. And you think about those double contrast enemas or single contrast enemas that you've seen pictures of before. So that can be done. And there's actually good data to show that that reduces fetal dose. And that's something that we are doing here. Now, the challenging patient. And this is the one which is challenging not only from the imaging side of stuff, but also from you guys. And let's consider first the obese patient. Not infrequently seen, right? And from a diagnostic perspective, certainly it's challenging. For imaging, it's a problem because the thicker the patient, the more X-ray beams you have to pass through the patient. So one, there's a higher dose. But two, even if you crank up the scanner to its maximum thing in a morbidly obese patient, you get a very noisy image. And that's just due to the physics of beam attenuation as things go through tissue. So the diagnostic yield in the patient has potential to be reduced in that setting. So there are some things, but we try our best. And again, this is the conversation that we have in those ones. The breastfeeding patient, again, that's an important one that you guys will hear about. What is the risk of contrast to either to my baby because I'm breastfeeding? And this is data that you can actually quote to them. And this is born from, there's ACR's American College of Radiology Manual on contrast medium. The reference is here. And if you look at the total bolus of contrast that we give a female patient, a lactating patient, less than 1% of it is excreted into the breast milk, okay? Which is a small amount. Of that dose, a further 1% is absorbed by the fetal GI tract, or the infant GI tract. And the risk to the fetus is not so much toxicity per se. Well, there's issues of toxicity. There's issues of hypothyroidism. Now, that tends to be more of an issue in the setting of the antenatal diagnosis and application of this sort of stuff. But there are theoretical risks of direct toxicity and allergy sensitization. But to this point, there's no real data to support that, but this is just conjecture. But suffice to say, you can counsel your patients in that if they do undergo it and the question comes up, it's a really small dose, and the risk to them is significantly less. So that's a conversation you guys can have and quote that. The acute kidney injury, renal failure patient. So we have guidelines here, which, and now with the Hugo era, where you have to put in your request, there is a spot, and I think there's an EGFR calculator that's built in. So if the patient's calculated EGFR comes less than 30, give us a call. You know, let's have that conversation, because the risk of long-standing renal toxicity is significantly higher the further reduced your patient's renal function is. So that can be a conversation where, you know, you're worried about PE or some other examination or some other question, and are there ways that we can find another way to help answer the question you have for us. In that intermediate stage where the EGFR is between 30 and 60, there's a bit of a gray zone. And some of you have had this conversation with afterwards, suggesting just let's hydrate the patient to clear the contrast. There's discussions about role of NAC or N-acetylcysteine. The data is variable in its utility. And I think in an emerge setting, could be of some a debatable utility for that one. Okay? So with that, I will pause. Now, PE is an annoying diagnosis. I recognize that. It gives me headaches. You know. But diagnostic algorithms exist for you and for me to help work these folk out. And if we utilize these algorithms appropriately, we can do some cost cutting, save it, and make sure the patients are getting the right test done for the right clinical question. You know, my end of the world is one part of that algorithm. Feel free to talk to me accordingly. You know, I don't bite. I sit in an office which is about 10 by 12 and it's in the dark, so I sometimes crave some human contact. My texts will speak to that. So just give a call, okay? With that, I'll take questions if need be.
I think in the interest of time, we'll take questions at the end, and we'll take a quick break. So who had a drink, stretch your legs, mingle a little bit, come ask questions if you want, and then reconvene in 10 minutes. 5, 10 minutes.
Great, thanks. Oh, good. Wasn't too sure about overstep.
No, that was great, and I think you're going to find some nice questions at the end if you can stick around. And you covered kind of all the. I had done a survey of all the kinds of questions that people would have, and I think I covered a lot of them.
Yeah, tried to follow up, and some more recent studies have shown that the recurrence rates in patients with deep vein thrombosis, when it's unexplained, might be up to around 13 to 15% per year. And the other problem is that anticoagulation is associated with clinically important bleeding in a non-negligible proportion of patients. So some estimates of the annual bleeding risk while patients are on anticoagulants are that about probably anywhere between 2 and up to 7% of the patients in some population-based studies develop some form of bleeding, with major bleeding with an incidence of about 7 cases per 100 patient years and a case fatality rate that is not really very low. 13% of the patients with a bleeding associated to anticoagulant therapy are going to die from it. So this is something that highlights the importance of doing a timely diagnosis and also doing a correct diagnosis, because if we start anticoagulate patients who do not have a clot, we're going to be causing harm in a proportion of patients that did not need this treatment. So the signs and symptoms of VTE, both DVT and pulmonary embolism, are non-specific, and that's a major problem. Most of the pulmonary emboli will come from thrombi that develop in the deep veins of the leg, and then we need diagnostic imaging required to confirm all of these diagnoses. So a crash course on anatomy, so we call proximal deep vein thrombosis and distal deep vein thrombosis, and they should not be called thrombosis below the knee or above the knee, because that doesn't tell us anything. So a proximal deep vein thrombosis is anything that happens at the trifurcation level in the upper part of the calf, which is below the knee, but it's a proximal deep vein thrombosis. And anything that happens above that level is considered a deep vein thrombosis that is proximal, and that needs to be anticoagulated. And in the cases of thrombosis that arise in the distal veins of the calf, what we call an isolated calf thrombosis, those are the ones that involve only the tibial or peroneal veins, but do not involve the trifurcation. And those might not need to be anticoagulated, although there is a current debate in whether these patients should be or should not be treated. But I am not going to discuss that on this occasion. So what do we have in terms of approaches to diagnose VT? Well, we have all of these conditions, and we know that, so the first suspicion is obviously a patient history, and then the patient comes to see you guys, and then you find clinical symptoms and signs, and then you apply one of the multiple probability scores on laboratory testing and imaging testing. But how do we use these things? And that's a major problem and the major emphasis on my talk today. In the case of deep vein thrombosis, the clinical signs and symptoms vary, but they are not specific for this condition. Leg pain can be caused by a myriad of conditions, and the least frequent of them probably is going to be deep vein thrombosis. Yeah, so much more frequently due to musculoskeletal injuries and things like that. But it's the most common one as well. So in patients who actually have a deep vein thrombosis, the majority of them are going to have some sort of leg pain or tenderness, although it's not absolutely necessary. We will also have some things like edema, calf swelling, dilated veins, discoloration, and some other things. But these things are not specific as CVT, as we said, and they can have also be present due to the occurrence of some other conditions, such as the ones depicted in the slide, in particular cellulitis, abscesses, and compartmental syndromes, which, it is important to say, do not exclude the presence of a concurrent deep vein thrombosis in these patients. So if a deep vein thrombosis is still suspected, the patient should be investigated. So, as you can see, if we are going to confide only on a clinical gestalt to diagnose these clots, it will really depend on the experience of whoever is applying these criteria. So you might say, well, I think this is a clot, and then you're probably going to be okay if you have a very experienced clinician in this area. And if you are not a very experienced clinician in this area, you're probably not going to be okay. But then that pretty much stands for everything. So we cannot rely only on the patient's history and clinical exam alone, okay? And also the signs and symptoms are common to other diseases. And so the problem is that what are we going to do? Because if we start imaging every single patient that comes with a clot in the leg, or with a pain in the leg, there's going to be a pain in the butt for us, okay? And imaging is not always accurate, it's expensive, it's time consuming, it's not always available, and the vast majority of people do not have a deep vein thrombosis. So in those patients with symptoms, we can apply all of different clinical pretest models that can be used to determine what is the probability of these patients to have either a deep vein thrombosis or a pulmonary embolism. And then we can simplify these by using standardized approaches to assess these symptoms. And this is where the clinical pretest probability or prediction rules come into play. Because these provide a standardized and a quantitative clinical assessment, and it will also imaging for ruling in or out this condition. And you can actually define different levels of probability as low, intermediate, or high, or likely or unlikely in some of the modified versions. And then you can combine these with other tests, such as laboratory tests, such as D-dimers, as Mark had already previously shown. And all of these will provide us with a diagnostic algorithm for this condition. So the clinical prediction rules are designed to assist the medical decision-making process. And they will contain a number of different variables, and then they can use also simple diagnostic tests, and in this case the D-dimer. And they will basically suggest a course of action in terms of treatment and diagnosis. If a patient has a low probability of having a clot, and then he might not need any further imaging. As a general rule, how do we use a clinical pretest probability? It's a very simple approach. If a low probability of disease is present in a particular patient, and you have a negative test additional to that low probability, this combination is likely to rule out the disease, but a positive test will be less likely to rule in the disease. That means that if you have a negative test, you can most reliably rule out the disease. But if the test is positive, you can't tell the patient has the disease. And that applies as a rule for everything, not only for deep vein thrombosis, it's a general framework for all the clinical pretest probability rules. The same happens on the contrary. If you have a high probability of the disease, a negative test will not be enough to rule out the disease, but a positive test will provide further support to the notion that the patient might actually have that disease. So in the case of deep vein thrombosis, you are pretty much familiar with the Wells scoring system, which is the most extensively used system in America. And it includes a number of different points that I'm pretty sure you're all familiar with that will provide a number of different levels of probability. And you can use it in its original fashion that divides the probability as low, intermediate, or high. Or you can use it in the modified fashion, which has been very well validated in a number of studies and provides a much easier approach. The DVT will be likely if you have 1 point or more, but if you have 0 or less than less points, because you have some negative scoring systems, negative items, the DVT will be unlikely. One of the caveats of this system and all of the other systems, and in particular the Wells scoring system, is that it has a very interpretative variable, which is the presence of an alternative diagnosis at least as likely as a deep vein thrombosis. So if you have an alternative diagnosis that you think it might be as likely as a clot, that also comes back to your level of experience and expertise. And this has been one of the criticisms of this score. But in general, this score has been very well validated in a number of different settings and studies. What is this? So you have a combination of a low pretest probability for DVT and a negative D dimer, and you will rule out the presence of DVT in symptomatic patients. Or if you have a low probability and a negative moderate sensitivity dimer, and as Mark was telling before, you will have differences in the performance of the different reagents that you can use. And then you can obviate the need of an ultrasound. Or if you have, for instance, a combination of a low and moderate probability with a negative high sensitivity dimer, then you're not in ultrasound. So you need to know what kind of dimer you are using. And this is what happens. All of this is based on what's called Bayesian probability. So you start from the fact that you know what is the proportion of patients with a condition. So we know that if you apply the Wells score rule for deep vein thrombosis, in those patients who have an unlikely score, you will have only about 5% of them that will actually have a deep vein thrombosis. And then what you do is you basically add a D dimer. If you have a likely score, about 30% of them will have a deep vein thrombosis. And what happens here is that if you are going to image every single one of them, you're going to be doing 7 out of every 10 ultrasounds for free. Well, not for free, for free clinically speaking. So you add a D dimer, and if the D dimer, depending on the sensitivity, let's say it has a negative likelihood ratio of 0.25, you use just a simple nomogram and you depart from a pretest probability of about 30%. You have a negative likelihood ratio of about 0.25, and your post-test probability is going to be in the order of around 8%. Still going to be too high for you to not do an imaging study. On the contrary, if your departing pretest probability is low, such as in the case of an unlikely score for deep vein thrombosis, if you use a D dimer in addition to that, the negative likelihood ratio will result in a post-test probability of around 1.2%, 1.4%, which is low enough for you to sensitive D-dimer with a low or moderate pretest probability, or a moderately sensitive D-dimer with a low pretest probability. There's no need for ultrasound, no need for anticoagulant therapy, and about 1/4 to half of probably does not have a pulmonary embolism. excluded VTE, and the difference was about, as I said, 5%. But in patients with excluded PE, in patients when the studies were negative, 0.4% of the CTPA had a VTE during the follow-up, which was 90 days, and about 1% of the patients with VQ scan had a subsequent DVT with a non-significant difference. What's interesting about this is that the all-cause mortality was twice as high in the ventilation perfusion scan as in the CTPA scan. Probably an ascertainment bias, because the CTPA would allow you to probably pick up some other diagnoses that you don't have. Which means that even though you find more clots with CTPA, there might not be that relevant or in clinical practice. And the other thing is that if you're going to do pulmonary angiographies in every patient with an abnormal lung scan, that's going to be effective, but it's not going to be cost effective. It's going to cost a lot of money and time. So that's why these are the preferred strategies with combination of the clinical scores and normal lung scans. What about the PERC rule, which has been really kind of publicized pretty much? The pulmonary embolism rule-out criteria. So this was published initially in 2008, and it includes all of these points: age less than 50 years, pulse less than 100, pulse oximetry over 94, no unilateral leg swelling, no hemolysis, no surgery or trauma, no prior deep vein thrombosis, no oral hormone use. So what they actually suggested is that if the patient meets all of these criteria, they don't have clot. Well, this is a study that was done by Mark Regini's group and Dave Ojeski in Switzerland and France, and it didn't work that well. So overall, that I would like you to go home with. The first one is that history and physical are paramount, and then you apply the model only, the VT is still a possibility. So if the patient comes complaining of chest pain and you find a 12-inch knife lodged in the left side of the chest, it's probably not a pulmonary embolism. Okay? So remember that the algorithms tell you how to investigate a patient, but not who to investigate. And in general, no D-dimer should be used to exclude VTE in patients with high pretense probabilities. Not as a single diagnostic or exclusion modality. Combined modalities perform better than single study modalities, and clinical pretest probability is crucial, so you really have to be able to apply this first from
The limited use code for atrial fibrillation has been used universally for just about anything you can imagine. So that's rivaroxaban, apixaban. Oh, and sorry, and importantly, rivaroxaban, I should emphasize, it can be used by itself. You don't need low molecular heparin. And on the studies, the Einstein studies that were done, about 40% roughly of the patients on the Einstein studies were completely heparin naive and didn't have any low molecular heparin at all. Or had just a day or two. So they had just until their diagnosis was made, and then were put on rivaroxaban. And so that translates into the real world as to what happens. So you don't have to, once you make the diagnosis, give them low molecular heparin for a period of time first. The next is apixaban, which is also an anti-10 inhibitor. It's a little newer. So it's more recently come on the market, and just very recently has got indications for venous thrombosis. It does not have Ontario drug benefit for venous thrombosis, and will be at least a year before it does, and will probably get the same 6 months as rivaroxaban did. It also does not require the use of low molecular heparin before. And its dosing is different. It has the high dose only for 7 days and then goes down to a lower dose. And also compared to rivaroxaban, it requires twice a day always, whereas rivaroxaban can go down to once a day. And so that's one advantage of rivaroxaban over apixaban for venous thrombosis, that you are indication in Canada yet. I think it's still trying to, but it's almost pointless because this drug does require low molecular heparin first for a minimum of 5 to 7 days before you give it. And then in terms as a comparison to the others, there are so many reasons to not use this drug. It A subset analysis of the Einstein studies, and my name is actually on that too. So I'm well aware of that, suggesting that for the cancer patients that were on the Einstein study that it worked, but we didn't put the sick cancer patients on the Einstein study. So if someone had pancreatic cancer or brain tumor or any serious cancer and had a DVT or PE, we didn't put them on those studies because we didn't consider that it was ethical, because these agents are basically equivalent to warfarin, and warfarin we know is way inferior. So the only way we're going to be using that in the majority of cancer patients is if a study is done to show that it's okay to do that. Now a study is planned, and it'll be interesting to see how it does accrue, because there's going to be some discomfort in enrolling patients potentially to not get low molecular heparin. Now there are some cancer patients that it probably is safe to use. For example, a breast cancer patient who's on hormonal therapy, that would probably be a low risk patient for recurrence. Or someone who's had low molecular heparin for 6 months but needs to continue on something but doesn't want to be on injections anymore, well, it's probably okay to use a new oral agent in majority of those patients as well, but not as upfront treatment for the majority of cancer patients. Now, who can be managed as outpatients? So we get back to the emergency rooms in the United States, and it's interesting. So we've been doing this, as we said earlier, for 15 years, and these are the criteria that we have used in our publications of outpatient. Basically, a bedside assessment. You're looking at the patient. Are they sick enough that they need to be admitted to hospital? So are they hemodynamically unstable? Do they need oxygen? They need parenteral narcotics to control their pain. They don't have a very high bleeding risk. They didn't just have an ulcer, bleeding ulcer last week that they were scoped, or had a brain surgery. They don't have another risk or reason for admission. They don't have pneumonia that needs intravenous antibiotics, or they just look otherwise well and look like they can go home. Now we have demonstrated that of the patients who present to emergency room and are diagnosed with pulmonary embolism, 50% of them are sent home or managed at home from this institution. So 50% are admitted to hospital, and that sort of proportion was confirmed by a paper from our colleagues in Ottawa, using these simple criteria. Now, some people in the Netherlands, they took our criteria, added a few other things, and called it the HESG criteria, and made it like it's something new and put a fancy name on it. We should have put a fancy name on ours before too. Call it the London criteria or the Victoria criteria or something, and then it could have been used. But we did. They basically confirmed the same thing, adding some things in there that, for example, it said the liver disease has to be admitted, or pregnancy has to be admitted, or things like that. But they don't need to be admitted. Now, there's all these publications coming out of states using predictors, high-risk predictors for PE, and they continually get confused about predictors for mortality versus predictors for who can go home. Yes, it's important to know who has the mortality at 30 days, but that, in most circumstances, has no relevance to whether or not they can go home today and be treated. Because all the DVTs everyone with a DVT, a cancer DVT, is at risk of dying within 30 days. So just, and it's not belittling anything here, but just because someone has a high risk for dying at 30 days doesn't mean you admit them to hospital. How are you preventing them from dying at 30 days by admitting them to hospital for 5 days to get low molecular heparin? They're still going to have that same mortality after you study that the rule is working in terms of identifying a low-risk population. So half women can stop. And interestingly, birth control pill we consider as, if that's the only reason in quotation marks, that's idiopathic. And stopping a birth control pill doesn't mean they have a low risk for recurrence. A birth control pill or estrogen use is a marker for being a young woman who has a BMI under 30. And so that's why they have a low risk for recurrence. It's true, and we published a paper showing that the history of use of estrogen is not predictive of a lower risk of recurrence. Like isolated as a predictor, it's not predictive. So it's a confounder for these other things. Age of 65, so over 65 is high risk. A BMI over 30 is high risk. Signs of post-thrombotic syndrome, so swelling, discoloration, unfortunately would be for our regular D-dimer. Pregnant patients, I just want to emphasize one point. There was an algorithm that showed you can do an ultrasound and DVT and treat. I disagree with that in that if they have symptoms of PE, you need to show whether they have a PE or not. Because if we start treating someone for PE on the basis of ultrasound, a week later their PE symptoms are worse, then we're doing imaging for their PE, but I don't have anything to compare to know whether they've failed therapy or not. So it's important to know exactly what you're dealing with from the beginning. And so for me, I would recommend that if they have symptoms of PE, that you do these chest imaging as the first choice, and only do leg imaging if they have symptoms there as well, or by the usual algorithm that the chest imaging was non-diagnostic or inconclusive, so to do serial leg ultrasounds. But if I get a woman who has been diagnosed on the basis of a DVT, but hasn't had any chest imaging, then I'm doing it that day myself. I'm asking the radiology to do it. But so you don't not image them because they're pregnant, you image them because they are pregnant. We need to know all these things because of everything else that's going to happen, and we want to be on certain grounds, firm grounds, to know how to best manage them later on. So we use heparin at a therapeutic dose. I usually take their current weight when it's diagnosed and look at the agents, Inohep and Fragment, and pick the one that has a pre-filled syringe that's closest to their weight and stick with that. Some say, well, you should lower the dose as you go on, or do anti-10A levels and all these things. Well, we don't do anti-10A levels because anti-10A levels are all over the place anyway. And if someone's saying, well, you can lower the dose later on, well, effectively we lower the dose by not increasing their dose because their weight increases as they go on. They all need scheduled deliveries, and for two reasons. One is to minimize the risk of bleeding, and the second, very important, is to allow for the opportunity to have an epidural. So it's not a good idea to allow them to go into spontaneous labor if at all possible. And so they have a delivery date that's picked by the obstetrician, and the mode of delivery is determined by the obstetrician together with the pregnant lady. And so they don't have to have a C-section because of this. They have C-section for other obstetrical reasons. They they take their injections in the morning, and so basically don't take their injection on the day of delivery. So then they're more than 24 hours since their last injection and can have an epidural according to ASRA guidelines if they're on therapeutic dose. And if they're on prophylactic dose, because of previous history, then it's 12 hours, but we still do 24 hours because sometimes you get an anesthesia physician who's still uncomfortable with 12 hours, even if it's a prophylactic dose. And then they resume the next day, at least 12 hours postpartum, usually with just a prophylactic dose the first day if it was a therapeutic clot, and go out, back up to therapeutic the next. And fragment, low molecular heparin and warfarin are both fine for breastfeeding. And low molecular heparin doesn't cross the placenta. Now, conception issues are that first, low molecular heparin, no issues at all because it doesn't cross the placenta. Warfarin is fine to conceive or to be on up to about 6 weeks. For certain 6 weeks, maybe 7 weeks. And so you don't have to get off of warfarin to get pregnant, as long as your periods are regular. I have some women who, or have had, not currently, some women who are on warfarin, but their periods are regular. So they're at risk of getting pregnant, but they don't reliably know when their period is late. And so what we've done is basically do a pregnancy test every time they have an INR every month, so that we'll pick it that way. The new oral agents are completely uncertain. They are small molecules, so they will cross the placenta, and all women were excluded from participating in the studies if they were at risk of getting pregnant. And well, if they got pregnant, they were removed. So basically, we counsel them that as soon as they know they're pregnant, tell us so that we can stop it right away, because we don't know what's going to go afterwards. Just a couple of other quick issues. First is birth control pill. A woman comes to emerge and she's on the birth control pill, gets diagnosed with a clot. You don't have to stop the birth control pill. Please don't, because they're going on agents that we don't want them to get pregnant. And now we're anticoagulating them, so they can stay on it as long as they're anticoagulated. Yes, if they stop anticoagulation, they can't be on it, but we'll look after that. But you don't need to tell them to stop. If someone has history of clot and they come in and they have new symptoms and they're on warfarin and their INR is 2.5, they can still have a new clot. So you can't say, oh, you're anticoagulated, so it's nothing to worry about. If their story is convincing and they have signs or symptoms that are convincing, you need to image them to find out, because the recurrence rate is 1% a year. We talked about diagnosing recurrence, so pick the imaging that was done previously and compare to the previous, and if there's nothing new, so if the ultrasound is the same or better than the previous, then it's not a new clot. Obese dosing, it's actually formulary to this hospital that there is no maximum dose for fragment. So you give the full dose per kilo once a day. And then the last thing is high INRs. There's been a number of studies showing that for asymptomatic elevations of INRs up to 10 in a randomized study, there's no benefit of reversing them. So just hold the warfarin. Yeah, obviously, if they're bleeding, then you need to reverse it, but it depends on the level of warfarin. It's going to knock the INR right down, and then it's harder to get it back up, so you need a higher dose. And then as that vitamin K wears off and they're on that higher dose of warfarin, then the INR is back up again. So again, it ends up being a yo-yo. So just 1 or 2 milligrams, which can be given orally. So last slide. So patient is diagnosed with a PE. You decide whether you think it's going to be an inpatient or an outpatient. If it's inpatient, then you refer to us. You give low molecular heparin. If it's at night or on the weekend, you just fax the referral to us. Then, as you know, we see it the next business day. We are instituting a thrombose pager, and we finally have the number. And so one of us will be available on that pager, the person who's going to be seeing the patients the next day. And so then we'll be better able then to maybe give you an exact time to have the patient to come, because it's not my day. I can't tell you what time Dr. Laser-Langner wants to see the patient, because I don't know how his clinic is that day. But if we do it this way, then we'll know when we'll be able to give you a time. Or you just fax it, and then we get it first in the morning, and we'll see the patient that day. And that's it. Thanks.
Okay, save up your questions, find a break, stretch your legs, get a drink, be back in 5 minutes. But you answered a lot of them. I did a survey of all 60 or 80 people, and then compiled all the questions. I didn't get it all done for like in time to you guys, but
what I did send you, and then it was it's pretty well answered. It'll be,
So we'll be
mortality predictors, but what are the mortality predictors? Like, he didn't list the mortality predictors. Right? Where did he go?
I don't think anybody would reasonably send home a saddle.
Submassive, right? That's or intermediate.
Yeah, or
risk.
a submassive.
So anything with RV strain, tropes,
Probably.
hemodynamic instability, or
Although
SATs.
I've been asked by medicine to send them home.
I know.
Are you sure they need to come in? And I don't really.
Yeah, it's a
100%
tell.
know.
Good for conversation.
Okay, I think we'll get started. This last half an hour presentation is going to be just a teaser for thrombolysis in the eMERGE. We're going to have Dr. Drew Thompson talk about some of the cases to stimulate your interest in critical thinking, and then Dr. Carl Theakston is going to talk about two of the recent or the big trials. Not necessarily a full critical review, but a review of the trials. And then we can proceed into a large group discussion or panel discussion where we can finally ask all your questions. So we'll start with Dr. Thompson.
Usually is not an arrest over there. It's usually someone that vagaled or just doesn't feel well. But this was a true cardiac arrest. It was a lady that had just had a ENT surgery, a uvulopalatoplasty, 24 hours prior. She was only mid-30s, but was feeling unwell the next morning. She went out for a smoke because she wanted to get more air. Didn't do so well coming back from her walk. She was a little bit tachycardic, didn't look good, and boom, arrested. So I arrived mid-arrest as part of the emergency response team as CPR was ongoing. She was in PEA. And to be fair, there was really no other cause for her arrest. We know she hadn't been bleeding. We didn't have anything else in our differential diagnosis, and now we're 15 minutes into a PEA arrest. This was before the advent of point-of-care ultrasound, which you all know I'm a fan of. And I made the decision to lyse her empirically because of tachycardia, some borderline SATs that morning, and a sudden arrest. Lo and behold, we got a return of spontaneous circulation within 6 minutes, and she did really well. She had some bleeding post-operatively, but she went home. And I remain convinced to this day, this is my one case where I made a difference. No one else was going to thrombolyse her and collapsed. Bystanders were great. They checked for a pulse, and they immediately started CPR. When EMS arrives, he's got a GCS of 15. He's alert and oriented, and he's going, I got a lot of pain, and presumably from the CPR. He arrived at the emergency room with a heart rate of 128. Oxygen saturations were not great on a non-rebreather. And when you ask him, although it's hard to delineate from the chart, and I won't get the physicians involved today involved, it sounds like he had chest pain for at least 12 hours prior, maybe a little bit longer. He's on no medications. This is his ECG. And we're not going to belabor diagnostic elements of all this stuff, but he interestingly has the S in 1, a Q in 3, and an inverted T in 3, and his blood work. I won't get into the diagnostic kind of processing that went on, but the physician was astute. For some reason, there's a D-dimer on the chart. I won't get into whether or not it was needed or not. Troponin of 288, but regardless, the right test was done. And someone went after PE, and I'm no radiologist, but that doesn't look like there's blood going in through here on multiple images. And he was diagnosed with an extensive pulmonary thromboembolism, overall large clot burden, and CT evidence suggestive of right heart strain. This is part of the diagnostic criteria for submassive or intermediate risk PEs, as Dr. Theekson will get into briefly. So he comes back from CT, heart rate's 128, blood pressure is 108 on 73. Would anyone here consider fibrinolysis, thrombolysis? He's got right heart strain, evidence of damage with tropes, and let's be fair, he probably died, but the CPR got him back. So who would do fibrinolysis? I realize not every systolic arrest. It took us about 5 minutes as we rushed him to the resus room. He started waking up and sort of swatting people away from his chest in the bag valve mask. And he had a slow return to his level of consciousness. He actually became quite alert again and talking. He remained a bit dusky, heart rate 128. Blood pressure we think was about 70 on 30 systolic. Hard to tell, we didn't have an art line at that stage. We weren't really sure of his sats, we couldn't pick them up, and he did look kind of like the color of your chair. Fibrinolysis now? So maybe more, although a lot of you were going to do it empirically initially. So what happened with this guy, he was subsequently transferred to the ICU very shortly after this arrest. They did get an art line, confirmed his blood pressure, and he received TPA, improved his color and hemodynamics within an hour. During his stay, he was diagnosed with bilateral DVTs, and he was discharged neurologically intact, functionally intact, day 9, on Fragman with thrombosis clinic follow-up. So an interesting case of one issue. Normal blood pressure at one point in time, yet has a bad disease. Low blood pressure at another point in time has the bad disease. And does that make a difference in whether or not you should choose to thrombolyse? A case that hits a little kind of closer to home because I was intimately involved with this one. 23-year-old lady who was otherwise perfectly healthy. She is on the birth control pills. I'll show you in a second. She'd been feeling unwell for a couple of days, is the story we got from EMS. She yelled out to her brother, "Go get mom, I don't feel right." Brother went upstairs to get mom. By the time they came down, she was seizing. The seizure lasted for about 2 minutes, and then she stopped breathing 2 minutes later. EMS was activated. This is not a girl with a seizure disorder. Bystander CPR was performed. EMS arrived, found her in PEA with a ventricular escape, and after about 8 minutes of endotracheal intubation, some epi, the usual ACLS standards, we got back to a ROSC. She arrives in my emergency room with a heart rate of 130, a blood pressure of 130 on 62, satting reasonably well on her 100% through an endotracheal tube, and her GCS is 3 or whatever it is with a tube. I sent her for an immediate CT head within 3 minutes of her arrival because I heard seizure, loss of consciousness, the breathing I wasn't sure. She's perfectly fine here now, but she's not awake. Sent her for a quick CT head. While she's over getting her CT head, parents come in, appropriately very concerned, tearful, everything. She had collapsed 3 days ago. She was out for a run, she blacked out, fell on the ground, got her wits about her, and sort of made her way home. Since that time, she's been feeling really anxious. She's kind of fearful about everything. She went to her family doctor yesterday, who started her on Cipralex and lorazepam for her new diagnosis of anxiety. So when I heard that story, I was a little concerned. So as she came back from CT, we put on the point-of-care ultrasound probe, and this is not a POCUS talk, although I'd love to talk about POCUS, a bad parasternal long-axis view, although it tells the tale. This is her RV in the near field, probably her left atrium and her aortic outflow tract here, and this is her LV. I think we can appreciate that her LV really has no fluid in it. Her RV is occupying way too much space in this section. So she has RV dilatation and an empty left ventricle. This is the view you're a little bit more used to, the subxiphoid view, where we see the RV is certainly bigger than the LV. So already we have our diagnosis in mind. I think I know exactly what's going on based on the story and what I have here. We sent her, I guess we have some blood work on her too. Interim. She obviously had arrested and stopped breathing for a while. This is immediately as she walked through the door. Nothing else of note, really. No tropes, no dimers. So what does she have? Bilateral pulmonary emboli with a large clot burden and evidence of increased right-sided heart pressures. She comes back to the emergency department, heart rate of 126, blood pressure of 140 on 88. Who would fibrinolyze this lady, thrombolyze this lady? Kind of a few less people now. I had planned to give her fibrinolysis. I had told the family I was going to do it. As I was sort of preparing, getting the drug to the bedside, ICU arrived. As ICU arrived, they had the very appropriate discussion saying, she is no longer an unstable patient, so should we fibrinolyze her or not? She is not in the arrested period, peri-arrested period, or unstable period right now. And so we had a collegial discussion, and she was not. She went up to the ICU. It raised a totally different question for me, which is an appropriate one for the hospital dynamics, which is who follows up the patients that Emerge initiates care on, and can I realistically initiate care when we have a disagreement and the consulting physician, MRT, disagrees with me? So we had the collegial discussion, and they were going to reassess her up in ICU, which is required prolonged inotropic support. By day 4, they're having difficulty with oxygen saturations, with things that look like pulmonary infarcts. We're still on some inotropic support. Oh, Lord. I don't know how to fix that. Help. I know, but I can't get to my mouse on that now. So I can get that scene. Oh, thank you. Oh, sorry about that, guys. What you said, but I'm going to ignore it. So on day 4, they consulted CT because they were having difficulty managing her. The decision was made to do an open pulmonary thrombectomy. That was made. I know there are other management algorithms that I won't get into. But regardless, day 7, she was off her pressors. She was discharged day 14, and from all accounts, doing well in follow-up. As much as well as having had an open procedure. So our last case, this is a 60-year-old male. He is 4 weeks post-ankle surgery. He's had 2 days of increasing shortness of breath on exertion, but really no other symptoms. He just walked in like every other average bear that comes to the Emerge, saying, look, I feel a bit short of breath. And he comes in with his Aircast boot on. His triage vitals, heart rate of 110. He is hypotensive at 90 on 58, breathing about 24, and he's requiring some oxygen to maintain his sats around 92, 93%. In terms of the bedside assessment, this is a funny dude. He's cracking jokes. He is not in any distress. I was actually belly laughing a couple of times with some of the things he was saying, most of it inappropriate for today. He was a bit tachypnic, but he was a very comfortable looking guy. And as I say, you see his Aircast boot. No other past medical history to speak of. His ECG, for whatever it's worth, just to bring up that 2-wave inversions we classically associate with ischemia, but they can go along with PE. We won't belabor that point. Again, a point-of-care ultrasound was done, showing at least an interesting finding. Anyone want to comment on the finding? RV, LV. RV is certainly bigger than the LV in this apical 4-chamber view. And there is an interesting finding where the apex itself is kind of being overridden by the RV, and there's sort of an asymmetric contraction, something called McConnell's sign, which is associated with PEs, although it is associated with other features as well. But certainly a compelling bedside ultrasound to tell me this guy's going to have a significant PE. Just because I had a little bit of time, we went down into his legs. This is his popliteal vein and his popliteal artery. And just on simple bedside compression, it's obvious that he doesn't have any compression of his popliteal vein. And blood work, again, not very helpful, a troponin of 33. What does he have on CT? Extensive bilateral pulmonary thrombus, very large clot burden, and enlargement of the RV, bowing, again, RV strain. How about this guy? He's now sitting there, heart rate of 110, his pressure is 89 on 57. Feels great. You have that CT. Yeah, I know. I just have to push the envelope a little. Yeah, it changes every minute. So whether it's 89 or 90, who would thrombolyze this guy? Weaker hands. Probably the same number, but just a little weaker. So fair enough. So he was not lysed. He was referred to medicine. He was treated in the usual fashion. He was confirmed to have a popliteal DVT. He received his fragment very quickly. He was off O2 by day 3, and he was home on day 4. And again, fragment with thrombosis follow-up. So I hope these cases kind of just give you a spectrum. They give you a spectrum of probably a sicker patient by parameters of RV, by troponins, by some hemodynamics, some that were ultimately very unstable and probably dead, and some that were not so unstable, or maybe unstable by their number. So what do we do with these patients? And that's really the question that Carl's going to review some of the papers on, which is these massives or intermediate risk PEs, and should we be getting involved and being more aggressive with them?
Okay. Can everyone hear me okay there? Yeah. So thrombolysis or thrombolytic therapy in submassive PEs is a very controversial area. And I feel like I've kind of been thrown to the lion pit this morning. So let me just proceed. This is a controversy, as I said, and I've been asked just to give a very brief summary of the literature. I don't have the time to go into each study in great detail to do a critical appraisal, so I apologize for that. I'm just going to kind of whip through a number of what I think are the most important recent trials, try and address this controversy. To start with, it's important to appreciate that pulmonary embolism is different than the usual kind of clot occlusions that we're usually dealing with. So STEMI or a stroke. Remember the difference are arterial occlusions. The issue there is ischemia. Time is muscle, time is... This is not PE. PE is an obstructive thing. It's not an arterial ischemic issue. And because of that, the usual rules that we kind of think in our head when we think about clot obstruction probably do not apply. The other thing to appreciate is that thrombolysis is of uncertain benefit in non-massive PE. And thrombolysis, we do know, increases the risk of ICH and serious bleeding. This issue, the issue of thrombolysis for submassive PEs, comes down to a risk-benefit calculation. And I will get into that in a little bit further in my closing comments. I want to touch on these recent trials, the Moffitt trial, Topcoat, Pitho, and there was a recent meta-analysis done, and I will touch on that, although I will not go into great detail in the meta-analysis because it would take too much time, but I will touch on it. So the Moffitt trial, published in 2013, I think is really the trial that for emergency medicine started some of this controversy going, made us start to think, are we doing the right things with these patients? The authors of that trial decided to use what they considered safe dose thrombolysis because it was known that thrombolysis increased the risk of bleeding, and so they wanted to try and avoid that complication. Say, listen, if we give a safe dose and there's really no risk of bleeding, hey, thrombolysis probably is a good idea for these submassive PEs. They used half dose or 50 milligrams of alteplase in patients with evidence of pulmonary hypertension in moderate PE. Randomized trial, single center, open labeled, and a small trial, 21 patients. Randomized, 61 got to thrombolysis and the control group was 60. This trial was not powered for mortality. And the outcome assessors, and we'll get into what the outcome was, were blinded. While it was an open trial, the assessors were blinded. These are patients who are normal-tensive, symptomatic, and their definition of moderate, and it's important every trial you look at on this subject to look at what their definition of moderate or intermediate risk is. In this trial, it was an imaging definition only. And their imaging definition was they had to have 70% clot involvement of either the right pulmonary artery or the left pulmonary artery, or two smaller segments, two lobes that were 70% involved. So one big one or two smaller ones. Or if a VQ was done, two lobes or more involved. You obviously can't assess the amount of involvement in the artery, but that was their definition of what they called moderate. Notice that this is not a clinical definition. They have to be normotensive, they have to have symptoms of PE, and they have to have these imaging findings. And by their definition, that made them moderate PE. Safe dose or half dose TPA was given. You can see how it was given, and they were all started on enoxaparin or unfractionated heparin. My recollection is that 70% of them were given low molecular weight heparin, 30% were given unfractionated heparin. And the same sort of ratio for the control group. They were all started on warfarin on their admission. So what were the outcomes? The primary outcome was determined at 28 months, so a fair bit of time, like over 2 years, and their primary outcome was the incidence of pulmonary hypertension, defined as a PA systolic blood pressure greater than 40 millimeters, on an echo. They also had a second primary outcome, which was a composite outcome of the incidence of this pulmonary hypertension by this echo definition or recurrent PE. So that was their composite outcome. They had a couple secondary outcomes, including safety outcomes like bleeding. So here are the results. So what you can notice is there is a statistically very significant and obvious difference in the incidence of pulmonary hypertension. These are normotensive patients. These are patients who had, we would say, a significant clot burden on imaging. And when they were followed up at 2 years, the ones that were thrombolyzed had dramatically lower pulmonary artery pressures. There is no clinical variables here. This is simply an echo on follow-up and an imaging at the beginning. If you also look at this, you'll see that the mortality was not statistically different, 3 versus 1. If you look at the mortality plus recurrent PE, which remember was one of their pre-specified primary endpoints, it just reaches statistical significance. And that's because there were 3 recurrent PEs versus 0 for the treated group. Also interestingly is there's a statistically very significant difference in the length of stay. Hard to know what to make of that given that it was open label trial. So the conclusions from the Moffitt trial are that there's no mortality benefit, but it was clearly underpowered to look at that issue. There's a significant reduction in pulmonary hypertension at an intermediate time frame of about 2 years or so. The clinical significance of that is unknown from this trial. And there were no intracerebral hemorrhages on this thrombolytic dose. So in neither group were there any strokes or bleeds. So one of their conclusions was this is kind of a safe thing to do. Wasn't a big trial, but again, they did have no bleeds. This paper got people very excited. Let me jump forward to the next trial, Top Coat, also published in 2013. They used full dose TNK plus low molecular weight heparin versus low molecular weight alone in submassive PEs. Multi-centered US trial, double-blinded, randomized, placebo-controlled, small N, 84 patients only. Clearly underpowered study. And the reason for that is the study was terminated early, not for any clinical or statistical reason, but because of politics, administration, and the primary investigator changed institutions and was unable to continue the trial. It was originally scheduled to have like 160, so basically half of the enrollment. So it was underpowered for its primary outcome, underpowered for mortality. Unlike the Moffitt trial, which looked at no clinical variables, and this was Jeff Klein's paper, he decided to include, because he wanted to address the issue of patient-oriented outcomes. What really matters to the patient? So he has a very complex composite outcome that does include a whole raft of patient oriented outcomes, which I'll show you. So in their study, adults with submassive P, defined as a PE on CTPA, normotensive, and evidence of right ventricular strain, which is hypokinesis on the echo, an elevated troponin, or an elevated BNP, any of those things. So normotensive, PE, and evidence by some measure of some RV strain or injury. All patients got low molecular weight before randomization, and it was a weight-based bolus, single bolus TNK or placebo. So here is a break. This is a difficult results thing to look at, because remember, he has this very unusual composite outcome that includes things like poor functional capacity, which was measured in a 6-minute walk test, low perception of patient wellness, which was done by an SF-36. These were at 90-day follow-up, recurrent VTE, and within the first 5 days, they looked at death and shock or intubation. So this is probably not maybe the best way to have a good primary outcome, but if I show you this slide, you maybe get a better sense of what they sort of found, is that people who got thrombolysis, 85% of them had none of those markers of badness. They had they felt well, they had no evidence of functional capacity impairment in follow-up, they had no death, they had no recurrent VTE. So, and in the other group, they got placebo, 63%. And there was a whole combination of things that took away from that amount. You can see this part here is much bigger. It's a collection of all kinds of things. And his point was, what percentage of people that got thrombolysis at the end of their treatment felt well? And that's what he was kind of looking at. And he showed this statistically significant difference to suggest that thrombolysis improves patients' outcome. The other thing is they also looked at a length of stay in hospital. This was randomized and blinded. And interestingly, they found the same thing as in Moffitt. People went home earlier. So presumably there is some effect of thrombolysis on the things that allow us to make decisions to say, hey, I think you can go home. The conclusions from Topcoat are there was an underpowered study for mortality and their primary outcome. No mortality benefit. There was a death in each group. One death in the TPA group was from a bleed in the head, and the one death in the control group was from PE. There's one death each. They kind of bounced each other off. So no mortality benefit. There is a suggestion of improved functional status and patient wellness, though. And the point estimate of hemorrhage here was 1 in 40, so about 2.5% likelihood of an intracerebral hemorrhage. The paper that everyone was waiting for and was published last year in the New England Journal is the PITHO trial. It is by far the largest trial that, again, is probably our best current evidence that looks at this issue. This was a multi-center, double-blinded, placebo-controlled randomized trial. They looked at the clinical efficacy and safety of TNK plus heparin or heparin alone in normotensive PE patients, what they called intermediate risk. And I'll get into a moment what that is. A fairly large trial, just over 1,000 patients, intent to treat trial. The primary outcome was a composite of death or decompensation within 7 days of randomization. Death or hemodynamic decompensation within 7 days. I will show you the results trial. First, sorry, this is the table 1. First note that fairly elderly population, older than the 2 other trials that I showed you. This is primarily a European study, and that's a common feature in European sort of PE studies. But just note that this is the mean is 70, so half the patients are older than 70 in this group. Also notice that almost all of them had a CTPA, not a VQ, as their diagnostic test. And also notice that 50% of them had an echo done within 2 hours. It doesn't say that here, but that was within 2 hours. They had an echo done in order to diagnose this RV strain. remember, they could have, anyway, okay. So here's the efficacy outcomes. Their primary composite outcome is right here, hemodynamic decompensation, right here. So, sorry, primary outcome is the top one right here. 5.6 versus 2.6. The composite outcome is death or decompensation, right? But there's no difference in death. The mortality is statistically not different, 6 versus 9. But their primary outcome is statistically significant because of the increase in hemodynamic decompensation. So their primary outcome, statistical significance, is driven completely by a higher incidence of hemodynamic decompensation. That decompensation could just be a drop in their blood pressure. It could be that they needed to go on inotropes. But it didn't result at the end of the day in any difference in mortality. So you can argue about what the clinical significance of that is. But look at hemorrhagic strokes. 2% of the TNK patients bled. There was actually 12 strokes, 2 were ischemic, and 10 were hemorrhagic strokes. There was only 1 in the control group. So that's a 10-fold increase in intracerebral hemorrhages for no mortality benefit. These are the same results. I just put them together in sort of what I think is a little bit easier table to appreciate. Placebo, this group of patients, so-called labeled submassive, had a mortality of 1.8% with just anticoagulation, no thrombolytics. The difference that was statistical was the hemodynamic compromise within 7 days. And there was the big increase in both extracranial bleeds and intracerebral hemorrhages. The death at 30 days was also no different. So the conclusions from the PETHOS study are that mortality for intermediate risk submassive PEs is actually lower than most people would think. So this whole group was 1.8%. And that's why it will be very difficult to do a trial in this population to show a mortality benefit, because you'd need a huge trial if that's your baseline mortality. There's no mortality benefit for thrombolysis. There is a 10-fold increase in ICH with thrombolysis of around 2% or so. And the long-term morbidity and quality of life is unknown from this trial, as suggested in Topcoat, where the suggestion was that there are quality of life improvements, there are morbidity improvements, but this trial didn't really address that, so we don't really know the answer to that. The meta-analysis that was done last year, the Chatterjee meta-analysis, has created a great deal of controversy because of its conclusion, which I will show you. And I don't want to get into the details of it because it could take the whole hour to go through this trial. But I do want to point out a couple things. They did one of the analyses they did looks at just intermediate pulmonary emboli, and I think there are 8 or 9 trials that try and answer the question we're talking about right now, which is thrombolysis for submassive PE. But one of those trials, the Ultima trial, is actually a catheter-directed thrombolysis, not intravenous. And the other trial I will highlight is the Fazzulo trial, where if you look at the anticoagulation, that is the placebo group, they had 6 out of 35 patients die. That is way out of proportion to any other trial. If you exclude both of those trials, this no longer shows a mortality benefit. This just reaches the point with all these trials. If you take out the Fazzulo and you take out the non-IV thing, that actually crosses unity. So there's been a lot of controversy about this trial and what it actually shows. Most of these trials are small numbers, and almost half of them come from the one trial, the PETHO trial, which I went through. The PETHO trial in the New England Journal last year is probably our best current methodologically sound study to try and answer the question. Many of these earlier trials, some of them in their previous stuff are like from the 70s, probably should not be included. Here's the conclusion, taken right from the paper. Thrombolytic therapy was associated with lower all-cause mortality in patients with PE, including the subset of patients with hemodynamically stable PE associated with RV dysfunction. Right? So people have used this meta-analysis and basically run with it and say, there is meta-analysis proof that thrombolysis improves mortality. But there is no individual study, and there's no high-quality study which shows that's true. Earlier in the paper, he says, enthusiasm regarding a potential mortality advantage observed in the current analysis of thrombolysis agent in intermediate risk PE needs to be tempered with pragmatism, especially in view of the significant association with major bleeding noted. My conclusions from this review of the recent trials are the following. The current literature on this subject is early and it's very noisy. It's very noisy because the interventions are different. Some are half dose, full dose, TNK, alteplase. The populations that they're studying are different. The outcomes they're using are different. It's very noisy. I do think there's a signal here, but I think from recent trials that I went through, I think it's still too noisy. I think we need more trials. Submassive PE, actually, if you take the whole group, and if you define submassive as normal blood pressure, but evidence of RV strain, dilated RV, bump in troponin, if that's your definition, that group as a whole actually has a 2%. There is no good quality convincing evidence in that population I just defined. There may be a signal of improved mortality in younger, higher risk subset of submassive PEs. And Drew the patients that he described are what I would call high risk submassive. They have not just a little dilation of the RV, they have big dilations of the RV. They don't have a little bit of a clot, they have large clot burden. They have blood pressures which are hovering in the 90-ish kind of things. They have had cardiac arrest. They've had CPR. Of the sort of what are being categorized as submassive PE patients. Thrombolytic therapy is limited by a necessary evaluation of the individual risks of serious bleeding and strokes. I didn't show the graphs here, but there is good evidence that high-risk submassive group, the benefit risk may weigh in favor of thrombolysis. And I think a couple of papers or patients that Drew presented would fall in that category. But if you just use a very liberal, wide definition of what you call submassive, and they are older, then the risk-benefit may not be there. In fact, the risk of bleeding may be greater than any mortality benefit. I think we need significant answers to some important research questions. What is the role of reduced dosage protocols? Because the Moffitt trial used half dose and showed significant hemodynamic benefits in pulmonary artery pressures with half the dose. So do we really need to use full dose like we use for a STEMI? Or can we get away with half dose TNK or half dose alteplase? What is the role of low dose catheter-directed thrombolysis? The Ultimate trial is the only trial that looked at that. There's a big trial going on that's trying to address that. How to better risk stratify submassive PEs? Who are those people who are at higher risk where thrombolysis would be helpful? And what is the long-term effect of submassive PEs on patients' outcomes, quality of life, heart failure down the line, functional status? We don't know the answer to that. This is my last slide, and it's my own personal bottom line, having looked at the literature. I think thrombolytic therapy is not appropriate for all PE patients who are currently categorized as submassive by that definition that we liberally, they're not massive, but they have some element of RV strain. And if you take that group as a whole, I don't think we should thrombolyze all those patients. I think there is a role for thrombolysis in a small set of high-risk submassive PE patients after a careful and shared assessment of their individual risks and benefits of bleeding and benefits. And this is not an easy subject. The controversy will continue, and I hope everyone stay tuned for new research in this area which will help sort out some of these questions we struggle with today. Thank you.
Okay, I'm just going to grab 4 or 5 chairs, and then we can have all the speakers down here, and we can finally get to questions if anybody has any questions left or any energy left. And then Carl and I will moderate, so to speak, the questions.
Okay, do you want to come to Alex, Mark? Oh, yes, yes.
From your presentation, so are we implying that massive PE then should be automatically thrombolysis?
Yeah.
You're implying, and that the term massive PE is based on a radiological diagnosis or clinical?
I think the generally accepted diagnosis for massive PEs, hemodynamic instability, blood pressure, systolic blood pressure less than 90. Yeah, and that's why Drew had the 89.
Yeah, I mean, you're going to be very tachycardic.
Yes.
Some people who aren't, really have that hypotensive, but we get the report massive PE.
Yes.
And so,
Yeah.
should we be thrombolysing them before they get hypotensive? But that's, I don't know.
So I think that, as I say, I think that's part of this controversy. That unfortunately, the term massive is unfortunate because sometimes it's used as a description about the clot burden. And when we use the term massive clinically, we're not talking about that. And so it's unfortunate that word gets used for both. But when we talk about clinically massive, we're talking about the population of patients who have a large PE, who have hemodynamic compromise with a blood pressure less than 90. That makes them a massive PE, just that alone, regardless of what the imaging sort of says. Yeah. Mark.
That term's been massive versus not. I'm very reticent to use that term because of the connotation. So therefore, I'm advocating that you just describe what segments and number, location, proximal, distal, either main, saddle emboli, that sort of thing. Because if you start getting into those sorts of things, not to say that necessarily you guys will act upon that, but it carries with it some connotation. So I'm more just do the anatomic description and then go from there.
here. I've got some questions.
There's one over there.
Oh, I'm sorry. Yeah, Roman?
In the diagnostic evaluation of pulmonary emboli, even in the patient category, I noticed that the D-dimer played a role later on down the diagnostic algorithm. Does that mean that we should be ordering D-dimers even in high likely patients? Or does the D-dimer, if it's checked a week later or something after, or a couple of days later after the ultrasound is done, still as meaningful?
It only matters if you have a high pretest probability with a negative imaging, and then you do the D-dimer. But if you start ordering D-dimers frontline for everyone, and then you decide what you're going to do based on that, that's not the right thing. And that's for both PE and DVT. So it plays a role. So you have a patient with a high pretest probability, you have to image either way, okay? So you do not base your imaging approach on the presence or the value of the D-dimer for a high pretest probability patient. Okay, so you do have to image the patient. Now, if the imaging study confirms the clot, even better. If it does not confirm the clot, then's a time when you can use the D-dimer to make further decisions.
Let's go to Terry.
Yeah, this is sort of a follow-up question, but in our desire to try to minimize the amount of time people are in emergency departments, so working up someone who's a pre-test high for PE, what is the cost of the D-dimer in the lab? Because if they come back with a negative imaging study and then we're adding a D-dimer to figure out whether or not they need a repeat ultrasound in a week, does anyone know that?
I think it's $5.
One would argue versus an extra hour and a half of charge may be worthwhile ordering it as part of your workup in a high pretest probability.
On an individual patient basis, it really doesn't matter, but if you're going to be talking about 2,800 patients a year screened for probable pulmonary emboli alone, and so just do the math. So there are some economic evaluations, and it doesn't work that well. Okay, again, with all the caveats of the economists, which are a lot.
Drew? Follow up a little bit on that diagnostic algorithm. I think I saw two different things there with CT normal. And can we stop there? And is there a time when you can't stop with normal CT in your workup for PE?
In the old days, we called CT negative because it wasn't sufficient. But now we can call it as normal. So DQ is normal. If the CT is adequate study, demonstrating anything than normal.
So there's no need for follow-up leg ultrasound using a D-dimer, even if it's a high-risk patient population, high pretest.
Well, I think Dr. explain more about the Bayesian business, so there's some you have a person that you're just still really uncomfortable with, and I would do further imaging. That's going to be the minority.
Yeah, that's one of the things. I mean, all of these things provide a general framework for investigating these patients, but clinical gestalt is still important. So if you, for instance, if you have a patient that comes, and I had that several times. So the first patient I saw when I came here was a young woman who came with a leg that was like this big, okay? And she had an ultrasound that was negative, then she had another ultrasound that was negative, a third ultrasound that was negative. She went going on in and out of the emergency room about probably a couple of months. And then she was found to have a calf clot in an MRI. And between that calf clot in the MRI and the time that they referred her to me, she came back to the hospital with a pulmonary embolism that almost killed her. So you take a look at that and say, well, there's 4 ultrasounds that are negative. That leg looks like a clot. Well, then the ultrasound is wrong. Okay, and ditto. I mean, she had a massive iliofemoral clot, and that we found in a CAT scan. So the imaging studies are not definitive. They do have limitations as well. If the patient is extremely big, it's probably not going to work that well. If the leg is extremely swollen, you might not see anything. Or you might also have, for instance, about 15% of the patients have duplicated deep venous systems. So if you do an imaging study there and you don't find a clot in one vein, you might have a clot in the duplicated vein, which still needs to be treated. Okay, so
investigating the pelvic vein thromboses or the abdominal components of those thromboses is obviously a difficult area for us, where we get a negative study, but you're still quite suspicious.
exactly. I mean, it's my rule of thumb is if it stings, it probably isn't involved there. Okay.
People over the past few months. Can you anybody give us any hints on the COPD and AFib populations? We see tons of those. We know, well, some of the literature suggests we miss a lot of PEs and COPD, I suppose. Are there any pearls or hints or use of the D-dimer or not in the atrial fib population and the COPD population? We find those particularly difficult to decide. Do they have a PE or not? Do we go there?
Are you talking about patients who present to emerge with symptoms consistent with PE? Or are you just talking all comers with AFib? If it's new onset AFib, do you go looking for
They're
PE?
pretty non-specific when they come in with COPD with shortness of breath. Right?
Sure.
And how do you blame it on COPD versus PE?
Yeah.
Chest X-ray normal. That could still be. That's probably not PE still. But when do you kind of go there? Atrial fib populations. Do we use a D-dimer? They're often elevated, but PE can stimulate AFib. When do you go there? If it's a slam dunk PE with your classic symptoms, well then we would investigate. But any pearls?
I go back to the guidelines in the radiograph. If you have a hyperinflated patient, it's not really different from previous work. This is a known patient who's been worked up in an institution. You can. Sorry. So what I'm saying is, you can revert back to your established suggested guidelines. If you have a hyperinflated patient and there's no change on the radiograph, if you have the luxury of a previous, you can just lapse into your normal assessment pathway. If it's abnormal, if it's a COPD exacerbation, and you'll always see some new crud at the bases largely, you're kind of still a bit scuppered now. On balance, though, most COPD exacerbations who come in are COPD exacerbations, right? The respirologists in the crowd who can attest to that. They're not coming in necessarily because they have embolism. So if the story fits, sputum, all that other stuff that goes along with it, chances are you don't necessarily do it. But if it deviates from that.
Between the two imaging modalities, for somebody who has significant COPD, is there a difference? Is VQ, is it impaired at all by COPD, or does it have to be smallest emphysema?
If you have severe COPD, there may be reduced accuracy with the VQ scan if it's severe. But for the most part, in patients who don't have severe COPD, it certainly can be done without a huge compromise in accuracy.
Okay.
The comment about D-dimer, though, is that D-dimer should not be used as a screening test to decide whether to consider a diagnosis of PE. And that does happen.
Right.
So that's why, like for instance, if you come with these power plans, including like a VTE power plan, and it includes a chest X-ray and D-dimer, that shouldn't be done, because then you're going to be tailoring your clinical assessment based on the results of the D-dimer, which is exactly the opposite way that this is intended to be used. So you assess clinically the patient first, and then you decide if you need a D-dimer to rule out the diagnosis if your clinical pretest probability is low enough. Okay, and in that population is where you really need your frontline D-dimer, and if it's negative, then you ruled it out, and then you will pretty much prevent about 40% imaging studies on average using that approach. Okay, because the other way around, you will be risking the fact that if you have a high pretest probability patient with a negative DVT, with a negative D-dimer, you might think, well, the D-dimer is negative, he doesn't need any imaging, whereas that's not the case.
I have a question. Katie.
Yeah, so you mentioned earlier the patients who are on warfarin and come in and have a new diagnosis of clots, maybe they're on warfarin for their AFib, or maybe they previously have failed their warfarin. Should we be then starting those patients on low molecular weight heparin if we see them overnight in the emergency department?
It depends on how sick they are. If they look really sick, then it'd be reasonable to give them one shot. The chances of causing a bleed with one shot on top of the warfarin is very low. But then otherwise, I mean, you can still use Wells criteria. You can still use a D-dimer as well to help decide whether or not they need to be investigated.
So say they're investigated and we diagnose a new PE and it's the middle of the night, and so one of you guys isn't on call, or when do we start them?
Yeah. So if it's definitely a new event, then we recommend reversing the warfarin if they're on warfarin with 10 milligrams of oral vitamin K and starting them on low molecular heparin.
Just sort of a follow-up to on the newer anticoagulants or the directed anticoagulants, and they have a fail, so they're a new diagnosed DVT or PE on that medication. They've been taking it well. Is there like a hierarchy of failure for that? Do they then go on warfarin, or do they go on low molecular heparin?
Usually switch to low molecular heparin, and we are seeing that. I've seen quite a few failures to rivaroxaban. One of the things that so rivaroxaban half-life is about 12 hours. So the once a day dosing doesn't make a lot of sense, but that's the way it's licensed. And actually, theoretically, it might be better to use it, for instance, 10 milligrams twice a day instead of 20. So the same type of thing that apixaban. I think it came to a compliance issue with the pharmaceutical company. But we are seeing that, and I've seen quite a few. So I always put them on low molecular heparin for a short while, and then probably switch them to warfarin.
You would switch.
Well, I mean, warfarins are very good anticoagulants. It's actually much better than these ones. It has a number of different it's a number of different targets. Okay, so there's a lot of redundancy, and from a physiological standpoint, makes a lot of sense. And you can pretty much assess compliance, and if the patient is compliant, if the INR is therapeutic. With these ones, then you have to rely on what the patient tells you, and there's a lot of patients who are not very truthful.
It's like we switch our non-compliant, a lot of our non-compliant patients with warfarin to the new agents just so that we don't know about it.
and
Are all of our VQs the spec studies?
Yes, they are for this.
And
At the current time, all VQs are spec VQs.
what is the availability of the spec VQ CT study?
So the spec CT is something that we're not currently doing. We'll probably be doing it at UH at some point in the near future when we get a new camera that has a low dose CT attached to it with slightly better imaging capability. So that we have spec CTs at all sites, but they're not necessarily useful. It's more of a research tool at this point rather than a clinical tool. The one group had demonstrated higher sensitivities and specificities with it, higher specificities in particular, it's not sensitivity that it improves. So it would be, as it wasn't really demonstrated in multiple centers yet, but it does show promise, yes.
John?
One of the problems that we struggle with in emergency medicine is follow-up. And Mike, you spoke to the practical issue of whether you image somebody same day or whether you give them a shot of low molecular weight heparin and bring them back the next day. I think one of the issues that we struggle with in that situation is that it's not the same clinician that's seeing the next day. And I think very often it's kind of a yes-no situation. The patient comes back for a variety of different tests. In this case, obviously, it's a CT or a VQ. If it's positive, that's fine. They are continued on their anticoagulation and sent to you guys in clinic. If it's negative, I suspect that very often it's, your study's negative and you're out the door without a lot of extra thought going on. So I'd be interested in your comments, and Crispin, your comments about whether or not we would be well served to have a much more a better documented algorithm showing the thought process that would then give the follow-up physician a better sense of where they need to go if the test is negative, is really what it comes down to.
When we're talking about stuff, we're assuming that you've ruled all the other things. So pneumonia, pneumothorax, whatever else things are causing the symptoms, so you're entirely correct.
Well, the other issue raises Alex's comment about the test is negative, but you have a very high index of pretest probability. So at that point, should you be doing the D-dimer and this is brought back, and we are not all here. I mean, there's 60 people in the adult group, 60 plus. So I suspect there's going to continue to be significant variation in practice. So, I'm thinking there may be an opportunity here to actually improve the standard of care, recommending either an electronic algorithm that we all, into through the CPOE process, through Hugo, whatever, Cerner, or we actually do it on paper if it's too cumbersome to do it online. Crispin?
Yeah, it makes sense to me. I mean, that's been shown time and again, and to improve patient-oriented outcomes. Yeah, it sounds good. Good idea.
Which speaker had it, but one of them showed the graph or chart where people didn't follow the algorithms. They had a much higher recurrence rate of the pulmonary embolism after. And could you comment on what part of the algorithm they didn't follow? Was it that repeat ultrasound in a week that got them into trouble?
That paper, I believe that they looked at they assessed each situation, and they had an algorithm to see a different algorithm. It wasn't using the same one that we're currently using, but there were certain box criteria they had, and if depending on the clinical pretest probability, certain decisions were made and certain steps were followed, then yes, it was considered appropriate, or if it wasn't followed, it was considered inappropriate. So it was really specific to that paper. I think it was Roy et al. From Annals of Internal Medicine, I think it was 2006.
Pico? Yeah, I just wanted to talk a little bit about D-dimer. So in the low probability patients, which is the biggest thing because almost anybody who comes in with undifferentiated shortness of breath could obviously fall into that category. So it's criticisms that we over-investigate, under-investigate, and I know Wells has had a lot of criticism. The way that I've always approached that is it's sort of an extension of my gestalt. If they were a low-risk Wells, are they actually lower than low risk that I may not need to do a D-dimer and I have something to support me? And that's kind of how it's been used. It's gotten a bit of backlash because I just wanted to get the panel's take on any shortness of breath patient that doesn't have a chest x-ray finding and doesn't have something sort of right in your face that you can figure out in about 2 minutes could potentially get a D-dimer, and I don't want to see all of us now ordering a lot more D-dimers. Any thought on who is truly low risk? Just hoping to get some panel feedback on that.
There is no rule for when you consider the diagnosis. So everyone's different, and everyone has different comfort levels. But yes, you shouldn't consider the diagnosis in everyone who has a symptom above the navel. And don't do a D-dimer as a screening test to know whether you should do the PERC rule or whatever, And so until someone comes up with that rule, then it's just your comfort level and experience when you consider the diagnosis.
Yeah, it's like one of the take-home messages. Like these algorithms tell you how to investigate a patient in whom you suspect there is a problem. It doesn't tell you who to investigate. Okay, and that's what I was saying. So, for instance, you come here and the diagnosis is shouting at your mouth because the patient has a breast cancer and has a tumor this size that is just, well, that's the, I mean, it could still be that if the pain is there. I mean, yeah, and well, are you going to make mistakes? Of course we are going to make mistakes. We have all made mistakes in the past. We're going to continue to make Okay, but these type of process gives you. So remember, these things were meant to be used precisely in an environment in which you have to make clinical decisions rapidly without having to put a lot of thought into that. Because it's luxury to do that, because you are dealing with a bunch of different things. Okay, so and you might very well be seeing probably 30 suspected PEs per shift, or you might not be seeing anything because you work at St. Joe's and you only see, eye infections or whatever. So,
can I get you to comment on the clinical situation which arises too often where we're concerned about PE and dissection, right? So it's a sudden onset, if somebody looks sick, they got shortness of breath, they got pain in their chest, it may or may not be pleuritic, and when we call radiology for the CTPA, well, what are you looking for? Say, well, these are kind of both on my differential. I have equipoise for both. Could you comment on what you do sort of technically, whether do you do the same thing or is there a different study, or do you want to know about that potential differential?
Right. Okay, so 2 points. The studies to answer those specific questions are done differently.
Yeah.
It's a timing thing. So remember, PE, you're looking at the pulmonary arterial system, so therefore when you do an intravenous injection, it'll be imaged, you're triggering your scan at an earlier time point. Whereas more arterial, systemic arterial, any of those aortic things, they're done later. That's just the way it goes. And you really need to tell us which one you were really more worried about, because the sensitivity is different because you have differential opacifications in both vascular systems. Admittedly, can you occasionally see a big massive embolus? Yes, but the segmental crud that we've been talking about, you will not see if you do it in a dissection study. Similarly, depending upon the timing, and again, if our technologists get the timing on a pulmonary embolism study well, you should have absolutely no contrast in the left heart. And therefore, the entire left heart and arterial system will not be opacified, and you cannot.
Because I've heard one argument, I think it was maybe one of the radiology residents said to me, if you're really not sure and the patient looks really sick and they're a little hypotensive and they're short of breath and with sudden onset kind of pain, do the dissection study. He said that, there's likely, if there's a large PE, a proximal PE, we'll probably see that as well. We may miss smaller ones, but smaller ones probably aren't going to cause the sort of clinical presentation this person has. But I'm asking you if that's...
So that's fairly accurate, but again, it depends upon how the study is done. So
you can't do a modified study where you kind of get a little bit of both, obviously. double the
sure, and then you'll get a lot of these wishy-washy, can't exclude this and that sort of stuff, and then COVAX is having to contend with this sort of thing.
All right.
So the bottom line is, in an emergent situation, and most of the time you guys will have a better sense of what is going on, truthfully, tell us and we'll do the proper study for you, recognizing that there are limitations.
Rob. So we can agree that PE is a multidisciplinary, interdisciplinary diagnosis, given you all here and probably other players who could be here. You could imagine pulmonary, like respirology, maybe even cardiology, interventional radiology, vascular surgery, cardiac surgery. I mean, a number of players. This disease touches many different specialties. I guess there's one moment, though, in its management where everyone else, all of the allies kind of fade away, and that's when you're the emergency physician or the intensivist with a syringe of TPA in your hand, and everyone else is perhaps in the dark room reading the study or at home carrying a thrombosis pager or in the clinic seeing the outpatients, where you choose to be. And that's a lonely moment, high-risk moment, perhaps the highest risk moment in management of the disease, and as Carl pointed out, there's a lot of equipoise probably about the submassive group in particular. And Dr. Kovacs, you made a comment which I think, and I guess my question is, I'd like to seek maybe a going forward point as we struggle, as particularly the resuscitative physicians struggle to decide when to push lytics, that you guys as a hematology group and a thrombosis group aren't overly passionate or interested necessarily in being part of that decision-making process. That you're kind of leaving it up to the resuscitative physician based on their clinical judgment, knowledge of the literature, and other things, and that if we're to say look at a care pathway locally, maybe merge between ICU and emergency medicine, that you might leave that to us to make, or would you like to be part of that process?
One of the reasons I chose hematology is because at 8 o'clock at night I can be sitting at home. So we don't see those patients. I'm doing like all outpatients, and I've never administered thrombolytics. Not because I don't think it ought to be, but I just don't see the patients. And sometimes someone will call me and ask me what's the dose, and I say I have no idea. Look up on Wikipedia. You know, when I give a talk, I just say if they've got a PE and they look like they're going to die, then they probably should be getting it. So I mean, maybe we should be there in the merge or in the ICU helping with that, but we just historically have not been.
So I guess I don't necessarily think you should be or ought to be necessarily. I do think it's a resuscitative decision made by resuscitative experts, which would include the emergency physicians and intensivists and a few others. I guess ultimately, that as we struggle with a high-risk decision and seek solidarity often in those moments, phone calls can vary to any of those specialists we just mentioned. You'll get a call, respirology get a call, CT medicine will get a call, IR will get the call to put a catheter in to do directed lysis. But often there's a call because there's a lonely decision to make. And I think the path forward for us is one of the subtopics of today being the thrombolytic side of things is to decide as a group how to proceed forward with a high-risk decision and who would like to be part of that sort of deciding how and when that gets done. And seeing as we have you here and we have a lot of our group members here, it's fair to say that you would maybe hand that over to us to look after?
Yeah.
Okay. Your talk, but I guess it's actually just really helpful to have a sense of where we're going forward with this.
Our first meeting's at midnight. We'll hope you'll be there.
There was a comment made at one of the earlier talks about PERC and whether or not it has a place in the rule out of PE and whether or not you should use a D-dimer. I just wanted to get a bit of an informal poll. People here, are you using PERC? Okay, hand up if anybody is. Okay, who doesn't feel it's of use in our job? Drew? Mark? Okay. Could you could you guys comment on this or what you could?
Personally, it's just never played a role in my initial evaluation. I'm kind of, what you heard is the real decision making for me is, am I putting it on my differential or not? Is it low pretest or is it zero pretest? And if I make the decision in my mind, zero pretest, it's done. PERC's not going to help me with that.
If it's low?
If it's low, then I'll proceed with a Wells assessment.
Okay. Zero.
Yeah. If my Wells scored at 0, then I have to, probably consider whether, it depends on the fact, but I just have to consider whether or not it is on my differential or not.
Okay.
I don't find
So you would follow that with imaging as opposed to using, you would follow that with a D-dimer as opposed to using PERC?
I use Wells and D-dimer.
Okay. And Marcia, do you have any?
Well, kind of focused on including most of the things in the PERC rule. I can't remember the exact most of the time. I can basically include them when I'm talking to the patient. I just don't find it adds anything. That's kind of what Drew's saying. Either I think they don't have any risk for PE and I'm not going after it, or if I think they're low probability, then I'm putting them into more of a Wells criteria to decide if I and to decide whether to do that or how to use that. I just don't find it. I don't find it adds anything. Okay.
Are there any Americans here? We facetiously say that the PERC rule for American emerge physicians working in emerges with a very low prevalence of pulmonary embolism who don't know when to consider the diagnosis. But if in Canadian hospitals when it's considered, the prevalence is a lot higher and the PERC rule is not appropriate.
Even in that study, the Swiss study, the prevalence of PE in the low pretest probability group, and that study used a modified Geneva score, not the Wells score, it was about 6% in the PERC negative patients. So it's not low enough.
But that, I got to add to that, but that's on the background of an overall prevalence of 21% in that study, which is so far and above our population that I would argue that it's not generalizable to what we do. And what I would add on to that, that was a study done in 2011. 2012, we had a meta-analysis with 5 studies that took a look at PERC and showed a sensitivity of 97%. And I think to me, that's our population, and that's a study that shows that there's some direct applicability, and it to me proves safety for the use of it in our population.
And I do agree, it might well have it, but the clinic, the study that we would like to see is comparing the PERC rule versus a D-dimer based technique in low risk patients, which hasn't happened. And the Wells combined with D-dimer or the Geneva score combined with D-dimer is very well validated in a myriad of studies. So I don't think that we have the data to support that. It might well be the case, but we just don't have it.
Peripherally, you have to have a clinical probability and have all these things that make you think they wouldn't have PE. So these are generally patients who I kind of just put PE off my list, generally. So I consider it sometimes it may cause you to put it higher on your list and you D or you move it otherwise. The patients over 50 or the first positive, I think you want them up.
Yeah, I agree.
I don't think they have a PE so much.
It seems to me to be very, very similar to Gestalt anyway, and that's sort of. But I guess as I was learning and PERC was there, I sort of used that to help develop my Gestalt.
Yeah, I guess sometimes use it with different things just because these are things that might put you at higher risk of PE.
I agree. Yeah.
But I don't find it particularly helpful.
Mark, did you have a comment?
I did. Rob, in the setting of if you're choosing to push thrombolytics and that, and you're talking about the lone risk scenario, right? I get that. Interventional radiology, as you know, we've done catheter-based thrombolysis for patients, and interestingly, Drew's 23-year-old lady, I thought, I think I know this patient, and I'm surprised that in that scenario, and I'm not sure what the subsequent decision making had been, might have been a candidate for direct catheter thrombolysis as opposed to a big zip and thrombectomy. So, as you know, we've got service coverage for those sorts of stuff and local expertise, at least in this hospital, to do that sort of thing. So I'd argue that you guys are probably not completely in the dark, whilst I may be, but...
But self-referrals being phased out.
No. Just in the setting of medical decision and patient care, I don't think...
I think it's a nice intermediate option, to be honest. It does involve specialty, and it does involve low risk. It does involve an ICU disposition, which would be the same as push dose lytics. So catheter-directed lysis, I agree that literally, but I think the thrombosis guys to your left may or not know I'm not sure the literature is still lagging behind much as it is, I think, for other forms of lysis. Certainly safe and low dose continuous infusion kind of idea. So I think it's attractive.
It's certainly going to be safer, right? Because the total doses with a catheter drip are going to be like 20, 30 milligram.
They are lower. I'm not sure what the actual total. You've got far more localized injection as opposed to doing intravenous, unless you get all this other systemic stuff.
We'll take one more question.
Did you have another question, Ronald? Or?
Is there a question over here? If I can just ask one question, I think maybe Alex alluded just very briefly about the below the popliteal fossa, the calf ones. I know there's been some literature recently suggested there is a risk with those. What's the current thinking from your service?
Well, there's some literature suggesting that these clots might benefit from anticoagulant treatment. The caveat with those studies is that the study that we want to see is a study comparing anticoagulant treatment versus sequential imaging, because that's what has not been done. And these studies compare treatment versus no treatment, and granted, yes, you're going to find patients who are going to extend if you don't anticoagulate, and we know that. But what we don't know is whether that has any doing in comparing, for instance, putting 90% of the patients at risk for bleeding versus doing sequential imaging, where you're going to probably catch the same number of patients. So we still do sequential.
Is that something we should do through the thrombosis clinics if we detect a distal calf thrombus? Is that something you guys want to see and sequentially image them and make decisions about, or not?
Not yet.
We don't want them back either, though.
All right.
I know. So
All right.
when we do a study, we'll run them.
Yeah.
Okay, I think we'll wrap it up there. I want to say a couple thank yous. Thank you to a big help from Laura Foxcroft and Carl Peakston to plan this day. And then a big thank you to Tarek, Andrew Jones, and John for doing all the hard work to film the whole morning so that we may be able to review it later, or those who aren't here could see it. And then thanks to Crispin for sitting on the committee, Dr. Richards here sitting on the committee, and a big thanks to Dr. Kovacs, Dr. Warrington, Dr. Azalanger, Dr. Landis for coming and being part of this thought-provoking day. And hopefully we can maybe go forward having answered some of our questions and maybe towards an institutional algorithm for thrombolysis or PE. So thanks to everybody for coming.